Good afternoon. I'm Dr. Joss Atwal. I'm the Acting Deputy Chief Provincial Public Health Officer. I'm joined today by Dr. Joss Reimer, Medical Officer Health and Medical Lead for Manitoba's COVID-19 Vaccine Implementation Task Force. Today we're announcing 6 additional deaths due to COVID-19. 1 in the Northern Health Region, 1 in Southern Health Santé Sud, and 4 in the Winnipeg Health Region. I want to extend my condolences to all the families, friends, and caregivers of these individuals announced today. The current 5-day COVID-19 test positivity rate is 5.2% provincially and 4.1% in Winnipeg. As of 9:30 a.m. today, there were 59 new cases of the virus that have been identified in Manitoba. The total number of lab-confirmed cases in Manitoba is 30,471. Our numbers continue to trend in a good direction. The hard work by Manitobans is paying off and has made it possible for further reopening. The reopening is modest and gradual. The measures were outlined Tuesday and will go into effect Friday morning for the entire province. More details are available online. We can't let up now, though. We have more work ahead of us, and we must keep these numbers consistently as low as possible, both in total case counts and our hospitalization numbers as well. We can't undo all our hard work by reopening everything all at once, or too fast, or too soon. We want to maintain a continuous reopening, and to do so, we need to take our time and do it intentionally. To continue moving forward and slowly reopening, the fundamentals still apply. You need to stay home when you're sick. You need to wear a mask, wash your hands, cough into your elbow. You need to stay home and self-isolate if you're waiting for your test results. If you or someone in your household is waiting for test results, your entire household needs to self-isolate. We have to keep focusing on those public health fundamentals to make sure we can continue the reopening process and not have to take any steps backwards. I want to take a moment and thank all of our essential workers across the province who've been supporting all of us in immeasurable ways during the COVID-19 pandemic. These are individuals who put themselves and their families at increased risk in order to provide the goods and services that Manitobans depend on each and every single day. They are the backbone to Manitoba's economy. Early on in this pandemic, I heard reports of essential workers across many sectors being denied service and care because of their professions. Unfortunately, almost a year later, these reports continue to come. The COVID-19 pandemic has affected everyone in Manitoba. Healthcare professionals have had to adapt to delivering virtual services, enhanced safety protocols, PPE requirements, and many businesses face shutdowns. Their efforts to provide Manitobans with high-quality care throughout the pandemic has been exceptional. However, the reports continue to come to us regarding services being denied to Manitoba's essential workers and their families. It's disappointing. Stigma and discrimination do not have a place in our pandemic response. This is disappointing, but I am asking all Manitobans to step up and let's do better for these individuals. This is not how to treat others, especially those who are working so hard to help the rest of us. The Lunar New Year is starting on Thursday and Friday and is celebrated by the Chinese, Korean, and Vietnamese communities. Usually this celebration sees families and friends visiting for a period of time. Sometimes there are events planned. The current orders are in place to allow for 2 designated people added to your household and outdoor group gatherings of 5. Large public gatherings are not allowed. COVID-19 is spread through respiratory droplets that come from a person's throat or lungs or when they cough or sneeze. These droplets can fall on surfaces, thereby contaminating the surface as well. However, washing your hands before and handling and opening cards for Valentine's Day, as well as avoiding touching your face while handling these materials, will reduce the possibility of transmitting COVID-19. Students do need to practice good hand hygiene while writing and handling cards and maintain physical distancing when distributing them. If envelopes are being used, do not lick them closed. One suggestion is that students provide their cards to the teacher and the teacher does the distribution. So lots of people aren't handing out cards all at once. For adults, if you are seeing someone new, you could spend time outdoors. If you are not from the same household, the orders do not allow you to attend a restaurant together, but you could grab a coffee or a hot chocolate and go for a walk. Blood donations. While I encourage Manitobans to stay home as much as possible, donating blood is very essential and always needed. Please consider booking an appointment through Canadian Blood Services to donate and save a life. And finally, Manitoba continues to experience an extreme cold snap. It doesn't look like it's letting up anytime soon. We do need to take the cold weather seriously as well. It can have major effects on the human body, like frostbite and hypothermia. These effects are preventable if you take precautions. Limit unnecessary exposure to the outdoors this week. Be prepared with proper cold weather clothing at all times. And if you have extra cold weather clothing or can help Manitoba's unsheltered population in other ways, please consider doing so. I will now pass it over to Dr. Reimer.
Thank you, Dr. Atwal. Good afternoon. I'm Dr. Joss Reimer, Medical Officer of Health and the Medical Lead for the COVID-19 Vaccination Implementation Task Force. Earlier today, some of my colleagues provided media with an update on our workforce planning to ensure that we have the people in place as we ramp up our immunization campaign in the weeks ahead. These updates are posted online for all Manitobans to see, and I would encourage you to take a look at the website. They're posted on manitoba.ca/vaccine under the Data and Reports section. Despite ongoing vaccine supply challenges, Manitoba is making important progress in our campaign. As of today, we've hit a bit of a milestone in that we've administered 50,554 doses of vaccine, including 33,930 first doses and 16,624 second doses. We continue to be second in the country when it comes to ensuring that people are fully protected with a second dose of vaccine at 1,126 per 100,000 Manitobans. We are now returning to personal care homes, giving thousands of residents their second dose this week. We are building plans to immunize thousands of Manitobans in congregate living settings as soon as the vaccine supply allows. We have set out plans to partners with the doctors and the pharmacists so that they can administer vaccine in a convenient and familiar setting once we have a vaccine that can be delivered in that setting. We have a goal of building our capacity to be able to deliver 20,000 doses of vaccine a day. And just yesterday, I was proud to join some of our First Nations partners to celebrate the launch of a pop-up immunization site for healthcare workers, traditional healers, and knowledge keepers in Winnipeg. But today I wanted to take a few minutes to focus a little bit more on some of the medical issues related to the vaccine and how that connects into the work of the task force. So first, I'd like to talk about the risk of COVID-19 and how this has helped us design our vaccine priority list to date. We get a lot of questions about why our plans are focusing on the elderly first and why we are not also prioritizing people with underlying medical conditions or essential workers. The short answer is that older Manitobans are most at risk. Beaucoup de gens nous demandent pourquoi nous vaccinons d'abord les personnes âgées et pourquoi nous ne donnons pas aussi la priorité aux personnes souffrant de troubles médicaux sous-jacents ou aux travailleurs essentiels. Leur réponse courte est que les personnes âgées sont le plus à risque. The Manitoba data is telling us that those with a high-risk health condition have more than twice the risk of severe outcomes, that meaning hospitalization or death, compared to the general population. So that risk is substantial. Data at the national level tells us that those over 70 have at least 5 times the risk of severe outcomes. The Manitoba data tells us that those over 70 here are as high as 8 times the risk of severe outcomes. The age-specific rates when we look at people needing ICU and hospital care were also higher in people over the age of 70. So while we clearly see that people with underlying medical conditions might be at more risk than the general population, their risk is still not as high as those who are over the age of 70. But the data is not uniform. It doesn't apply to every individual equally. There are some people with certain high-risk conditions who are actually at extremely high risk. But there will be other people with that exact same health condition who are at much lower risk. So if we focus our immunization campaign on any particular health condition right now, we might be able to capture those extremely high-risk individuals, but we would also capture and immunize people who are much lower risk. And because our vaccine supply is so limited right now, that is not a viable option because it's removing doses from people over 70. We have to reach those at most risk, and the data shows us very clearly who that is. It is not a matter of vaccinating older Manitobans and those with underlying medical conditions. This is an either-or situation right now. Nous ne pouvons pas vacciner à la fois les personnes âgées et les personnes souffrant de troubles médicaux sous-jacents. Nous devons faire un choix. With the amount of vaccine we have, we can't vaccinate everyone all at once. But I also want to point out that this doesn't mean that we can't look at making changes in the future, particularly when we start to reach younger populations. And indeed, we are looking at the health conditions that are the highest risk globally in Canada and in Manitoba so that we can make these informed decisions as we move through the population. But right now, we need to start with people over 70 who are at most risk. For those who are waiting, I know that it's frustrating. I know that it's frightening and it's discouraging. So I'm asking for patience. As I've said before, if I could give everybody a dose today, I would do that. This is a life-saving intervention. We don't take that lightly. I don't take that lightly. The decisions weigh very heavily on me, on all of us. But the science and the data is what we're using to guide our decisions right now. So we need to use the vaccine to save the lives of older Manitobans. The second item that I want to talk about today is vaccine waste or vaccine loss. Believe me when I say that the people in our clinics, our focused immunization teams, and those providing COVID-19 vaccines in any other setting are very aware of how precious it is. Croyez-moi quand je vous dis que les gens qui travaillent dans nos cliniques et nos équipes de vaccination ciblées, ainsi que ceux qui administrent le vaccin contre le COVID-19, sont tout à fait conscients de la grande importance de ce vaccin. They are all doing their best to ensure we get as much vaccine from each vial that we can. I've spoken before about how Manitoba gets 6 doses from almost every vial of the Pfizer vaccine, even though the manufacturer originally said that the vial had 5 doses. In fact, most other provinces are not able to consistently get 6 doses from each vial, and many of them are reporting their counts assuming the vial only contains 5 doses. So this has ensured that we're able to provide more vaccines to Manitobans. And I really want to thank those frontline providers for their hard work and their success on this very challenging situation. But wasting a small amount of doses is expected in every immunization campaign. The manufacturers and the Public Health Agency of Canada told us to expect about 5% wastage. But through very careful planning and processes, to date, our wastage has been about 0.4 to 0.5%, so much, much lower at our fixed sites than what we were told to expect. As of this morning, we've administered over 50,000 doses of vaccine and recorded a loss of 246 doses. This is thanks to the hard work and the diligence of our immunizers. We know that over time, as more sites open, as we immunize more people, as we expand outside of our fixed sites, that number is going to go up. That's normal. In fact, we've been a bit hesitant to talk about how well we're actually doing right now because we know that the number is going to increase over time. But sometimes we need to waste vaccine. There's a number of factors that contribute to this. There could be vials that don't look as expected. They might be cloudy, they may have sediment in them. Giving a vaccine like that may not be safe. Someone might accidentally touch a non-sterile surface after the vaccine is drawn up into a needle. Or sometimes the person who's getting the vaccine might move just as they're about to get the vaccine. The people working in our clinics take out vaccine throughout the day to match what we have on hand to the number of appointments still remaining. So we're doing our best every step of the way, but it is possible there could be a few doses left at the end of the clinic. I think many of us have read or seen reports about inappropriate use of vaccine at clinics in other places, immunizing people who aren't eligible, for example, to use up doses at the end of the day. That does not happen here. All of the people working in our sites are eligible to be immunized, but they also have to make appointments. And because the vaccine can't be shipped to a different site, those doses that are left at the end of the day have to be wasted. But as I mentioned, the number of doses left at the end of the day is very small because we very carefully only use vials as we need them throughout the day. But we do also want to be clear that a campaign with zero wastage is not a safe campaign. We want our staff to feel that they can be honest with any situations when the vaccine or the syringe are compromised. That is essential for Manitobans to know that the staff feel comfortable telling us when a dose has to be wasted. Otherwise, Manitobans are put at risk. And I understand that hearing about wasted doses is frustrating, but an unsafe vaccine campaign would be even worse. So before I wrap up, one final comment on the vaccine. It is in short supply around the world, and as I've said, it is a life-saving intervention. Sadly, that means that there are people who are running scams to turn a profit. I am not aware of any of these scams occurring in Manitoba, but we have been advised that there have been reports across the country of people making unsolicited calls, offering vaccine for sale. The only way to access a vaccine in Canada is through the federal, provincial, and territorial governments. We are providing the vaccine to people at no cost. So if you are contacted about purchasing a vaccine, please know that this is a scam. You can report it to your local police agency or to Health Canada. And while unfortunately, sometimes these situations bring out the worst in people, after having worked with the teams at our focused immunization teams, the folks at the immunization sites, all of our essential workers, we also see that it brings out the best in people. So with that, we will open up to questions.
Thank you, doctors. Reminder to our reporters on the line, you will have one preliminary and two follow-up questions this afternoon. Up first, from City News, Mike.
Hi, good afternoon. My first question, I'm just reading here that it says the immunization plan for people over 80 is going to be slightly delayed. Can you just talk about when it was initially going to happen and what it's been delayed to?
So based on the supply information that we have from the manufacturer and the federal government, we had hoped that even as soon as the end of February, we might be opening up to elderly Manitobans. Right now, it's looking more like March, but I am optimistic based on the newest information that we have that we will be able to open up to elderly Manitobans in March.
Thank you. My second question, this is just seeking clarification on the point you brought up in your opening remarks. Has the change of counting each vial of the Pfizer vaccine to 6 instead of 5 affected any of the immediate vaccine planning of the rollout, or were you counting every vaccine as 6? I just wanted clarification.
Yeah, that's a great question, and there's a bit of technical details in our planning that are important to highlight here. For the first quarter of the year, we were planning using the number of trays, which is a certain number of vials that we get sent from the manufacturer. Because the manufacturer has changed how many doses they consider in each vial, planning for trays means that we're going to be getting fewer trays than we originally thought we would be getting in the first quarter. So this does affect our planning for March. We're expecting we'll get fewer vials in March than what we had originally been told as far as the number of trays. But what Manitoba had been doing after the first quarter is we had been planning using the number of doses that the federal government had told us to expect. So the change in the manufacturer label, that it's a 6-dose vial instead of a 5-dose vial, should not impact any of our planning after March.
And then my final question has more to do with restrictions than vaccines. With some restaurants saying that it's not worth to reopen at 25% due to either their small capacity or just thoughts that they would actually maybe lose money on this, has there ever been an idea brought forth to allow a business to apply for a special exemption if they can prove their safety protocols to maybe go to 40% or 50% of their capacity?
Yeah, thanks for that. There's a lot of unique circumstances out there in different businesses. I think that's the difficult thing with orders. The orders are a broad brushstroke. We don't have the capacity to look at each and every individual business or each and every even household. We had questions about households and designated people in that household as well coming in. So it's difficult. It's just a starting point. We needed to look at opening things up from a public health perspective. We looked at what would be the safest way to look at opening things up. We do recognize that some places might not be able to open up, but it does allow a lot of other places to open up. We aren't just opening up restaurants as well. There's a lot of other activities that are going to open up or business sectors as well. And again, I think we have to look at risk when we're looking at all that. So if we're just opening up one area, it might be able to do a little bit more, but we have to balance that risk once we start opening up other sectors as well. So these orders are going to be in place for 3 weeks. I think during during that time, we're going to be assessing that situation. If some businesses aren't able to open up when they would have been allowed to open up, then obviously we would be looking at those capacity issues and limits thereas. But at this point, we have to start someplace, and we made a decision to start at this number.
From CHVN, Taylor.
Hi, good afternoon. The sporting activities being permitted by the province are only outdoor or private instruction for young people. What other ways is the province looking at making fitness more accessible for youth?
So, I mean, youth can go outside. Again, this kind of goes back to the last question that we had. We are introducing a lot more ability for people to move around. With youth, parents have to move around with youth. Other youth, depending on their age, can move around on their own. But everything that we do opens up a potential interaction. The more interactions we do, the greater the risk of transmission. We aren't at 0 cases in Manitoba. We know there's cases floating around. We have to have a slow opening to be able to see where our case counts go to. And again, this impacts our hospitalization numbers as well. So for every case we generate, or every 100 cases we generate, we look at, on a sustained basis, we need 14 ICU beds, and then we need a multiple of that for beds for hospital use as well. So again, we have to start someplace. We're starting off slow. We understand that. There's plenty of opportunities for youth to go outside and exercise and partake in activities. We've gone to community centers. I've gone to community centers with my kids skating, and there's hundreds of people out there. And it's safe. It's outdoor. There's active exercise occurring. There's lots of parks to go into walks with. So there is a lot of opportunity there. It might not be the same desires or the same things that people were doing before we open things up, but there is ability to exercise and to partake in those activities as well.
And what should parents be doing or talking about when they're getting their kids ready for a practice or a private instruction?
Again, the fundamentals will be there. When we're looking at an outdoor practice, again, it's outdoors, so we know that the risk of transmission in outdoor settings is low. You still want to look at distancing as much as possible. If you're able to wear a mask while you're partaking in your activity, wear that mask as well if it's outdoors. Again, don't carpool when you're going to the same location. It should just be the household going and coming back to really limit that risk, really limit those interactions. Don't share water bottles, let's say. On the indoor side, it's one-on-one training. So again, that'll be smaller numbers of people, obviously, and there's a lot of procedures that these businesses will have to put in place to clean in between users. If you're sick, again, don't go anywhere. Stay at home, go get tested. So it's the same fundamental messaging that public health is expecting everyone to pursue when they are partaking in these activities.
And we've had a lot of people ask us this, but can you explain the difference in risk between sitting for an hour with your household bubble in a place of worship and doing that exact same thing in a restaurant?
Can you just repeat that question one more time?
Yeah, we've had a lot of people ask us what the difference in risk is between sitting for an hour with your household bubble in a place of worship and sitting for an hour with your household bubble in a restaurant.
Right. So sitting with your household bubble at home, those are those designated to individuals. That's what we've asked people to do. Restaurants, I think you're alluding to the fact that restaurants, we've said that the designated to won't be able to partake in those restaurant activities with the household. It's household only. And the reason is more on the enforcement side. How do we, specifically know? We don't have a database or an inventory in relation to who is a part of your household. Again, that can cause issues with other people or going out with dinners with other people that are part of that designated to. So we wanted to, again, open up slowly. We understand there's a limitation here on the restaurant use, but we do recognize still that we do have to open up slowly to mitigate, risk, to mitigate cases, to mitigate hospitalizations as well.
From the Winnipeg Free Press, Danielle.
Hi, good afternoon. Dr. Atwal, have you and your team in public health determined what levels of COVID-19 transmission would be considered sustainable in the province? So how much transmission can the public health system tolerate before we see uncontrolled or exponential growth?
Right. So, that's an interesting question. Obviously, with the vaccine rolling out right now, that'll have an impact. A lot of what we're doing is based on acute care capacity. It's based on ICU numbers, hospitalization numbers, the shifting of workers from one area of acute care to another area in acute care. It's based on the risk of mortality from contracting COVID-19 and those at risk as well. So those numbers are changing with vaccine rollout, theoretically, and we're hoping this occurs. We've seen some early literature of this. When we're able to get enough vaccine out to protect those most at risk, the system should be able to handle more cases, because more cases would mean at that point, once more people are vaccinated, especially the higher risk individuals, you get less hospitalizations, or less ICU visits and less deaths as well. So we're not there yet. Right, we have a limited supply of vaccine coming into the country. We're getting out as fast as we can into people's arms in Manitoba. So we are still a ways away from there. So there isn't an absolute number we're looking at. We're looking at a whole bunch of indicators in relation to restrictions and where the province can go from an orders perspective.
Thanks very much for that. And so I guess in follow-up, based on the epidemic modeling and perhaps our experience with COVID in the fall, how fast do you expect cases to increase with the next phase of reopening?
Well, that's a tricky question. We have a different level of restrictions in place right now than that was in fall. This is all based on behaviors of Manitobans. It's based on those interactions. So the more Manitobans do to protect themselves, to limit their interactions with individuals, will have a big impact in the number of cases that are generated. So there's different modeling out there. There's modeling where everyone does exactly what they're supposed to do. There's modeling where no one listens, and there's in-betweens. So you could theoretically get any number depending on what model you're looking at. But realistically, we have an idea of where cases might end up going, but it's all going to be based upon how Manitobans behave. It's how we behave when we go to that restaurant now. It's how we behave when we invite someone over. Are they that designated too? It's going to be based on those interactions. So it is up to Manitobans to keep our case counts down and to look at how we could loosen restrictions in the future.
Thanks. And I guess I'll follow up on that again. So can you tell the members of the public what it might look like when the behaviors are not, like when we're not following public health restrictions, when those behaviors are driving up case counts? What will we see as far as what will it look like when we get into kind of like a danger zone?
Well, again, difficult question to answer. I think we're going to have updates, regularly with the public. We meet with the public regularly through the week. We're very transparent in our hospitalizations and our ICU numbers and number of cases that are generated. And again, there's no absolute number where we hit this point, we're going to run into a lot of trouble. Obviously, we have people in hospital right now. We have people in ICUs right now. If we see a general increase, a trend up, we'll have to relook at that information, relook at the data and see what needs to be done, or can the system manage that? And then we're going to continue to look at that. So I can't give you an absolute number here.
From Global News, Shane.
All right, thanks for taking my call. First question I've got for Dr. Reimer, kind of following up on what you talked about earlier with younger people with immune compromise. So it sounds like we're not going to be giving them kind of a priority as we're looking at the age groups, but I'm wondering as we get more vaccine, whether individual cases might be considered once all the super sites are running, and maybe people outside of that age group would be considered if they're immune compromised at some point.
Yeah, thanks for that question. So when we look at Manitobans over age 70, we're seeing a case fatality rate of 19.4%. What that means is that out of every 5 individuals over 70 who have COVID, one of those individuals died related to COVID. That's a very high number, and that includes folks who were previously healthy. We don't see those high numbers in other groups, and so we need to prioritize that group first. But that doesn't mean that as we hit younger age groups that we won't start exploring other high-risk groups as well. What we need to do is, when we have this very limited supply, is ensure that we're providing it to the highest risk Manitobans. But we will absolutely be continuing to look at the evidence, to look at the local situation, and making decisions as we go, and nothing is off the table.
Appreciate it. I guess my next question, I was curious about testing for these new variants. I'm wondering what percentage or how much testing we're doing now for those new variants, and whether that's changing since we've seen the UK one in the province.
Thanks for that. Obviously, we announced our first B117 case, or it's also known as a UK case. So from a testing standpoint, we are screening our samples for the variants. So basically anything that comes back positive in Manitoba, our provincial lab is able to screen for the B117 variant. And thereafterwards, anything that screens positive gets sent off for genomic testing. So screening will capture what's called some false positives as well, meaning because it's a screening tool, we want to make sure we don't miss out on anything. So again, anything that shows up locally will get sent off nationally to get that genomic sequencing done. From a public health perspective, any test that screens positive as a variant will be treated as that until proven otherwise as well. On top of that, there's also genomic sequencing done for certain groups. So let's say international travelers or contacts of international travelers, suspected reinfections, those who are severe COVID cases less than the age of 50. We take some random sampling as well. We look at clusters or outbreaks and take some samples from there and send it off to genomic sequencing as well. So there's a lot of genomic sequencing done. And we're going to continue to build on those efforts as well in relation to other variants that might be around.
Great, thanks. And I guess I'm curious about those other variants as well. So that South American one sounds particularly bad. Is this testing that you're doing for the UK variant, is it different than what you're going to have to do to find these other variants, or is that kind of the same?
Yeah, so from the B1351 is a South American variant. There's a P1 Brazilian variant as well. So from a genomic sequencing standpoint, anything that's sent to NML in relation to those different categories I mentioned before, automatically they're genomic sequence for that. We're going to be screening for those variants as well within Manitoba, and I believe that's ramping up right now. I think over the next few days we should be able to screen for those others too.
Thanks a lot.
From the Brandon Sun, Michelle.
Good afternoon. I think this question would be for Dr. Reimer. We've received a tip that in the next week or two, all inmates at the Brandon Correctional Center will be vaccinated, while federally only those inmates who are medically vulnerable are receiving the vaccine. We also heard correctional staff are not being included in that rollout. Can you confirm any of this? And if this is so, can you provide the rationale for all inmates and not staff?
So we have said that we are providing vaccines in congregate living settings. And in particular right now in Winnipeg and Brandon, because we're using Pfizer in those locations, we are able to continue with sites in those two cities. So for example, we are intending in the next little while to visit places like Lions Manor Supportive Housing, like St. Amant, like Concordia Hospital. But each RHA is given the list of congregate living facilities in their RHA so that they are able to prioritize the list in the most efficient way possible. So I don't have the dates of visits to any particular location, but what I can say is that corrections is one of the congregate living settings that will be targeted through this approach, because the individuals there have very little control over protecting themselves. If a virus is in the facility, it can spread much more easily when people are congregated like that. But it is lower on the risk than some of the other congregate living facilities because, generally speaking, the inmates are younger than the populations in, say, the supportive living facilities. So because we're right now a bit limited to working on Winnipeg and Brandon's locations, because Moderna, we still don't have any confirmation about when we'll be getting our next shipment and how much. It's possible that some of the congregate living facilities in the urban centres that are lower on the list may still get their doses a bit quicker than the rural settings. But as soon as we get some confirmation about Moderna, we'll be ramping up all congregate living settings throughout the province immediately. And I do also want to flag that the reason that we're continuing to work in Winnipeg and Brandon is so that we can spare additional Moderna for rural settings. So we thought it was important to use Pfizer where possible so that all of rural Manitoba has more Moderna available.
Okay, thanks for that. And I'll follow up, I guess. You didn't really address inmates versus staff. So let's say the Brandon Correctional Center, as I was seeking to find confirmation about. How does it, can you just explain why inmates, not staff? And is that true even?
Sure. So right now, healthcare workers who are working in corrections are eligible for the vaccine, but that doesn't mean that all staff in corrections are currently eligible. If you look at our prioritization list, you'll see that staff in congregate living settings will progressively be included. So they are one of our priority groups. And as we move through the priority list that we have, they will be included. The timing of the inmates versus the staff is somewhat having to do with the logistics that as I mentioned, that we're moving through the urban congregate living facility residents first. But the other part of that is that truly the residents and the inmates have much higher risk of severe outcomes compared to the staff in those settings. And so largely speaking, one of the main reasons that we prioritize the staff in those settings is also to protect the residents. So whether that's a supportive housing or a personal care home or corrections, we are in part offering immunization to the staff so that they are not bringing the virus in to the facility. So we think it's important to ensure that the staff are covered, and we will be moving down that priority list. But it is possible that in some settings, the inmates could be offered it before the staff.
Okay, thank you. Final question is for Dr. Atwal. So can you please further explain the rationale dealing with restaurant attendants under the new orders? I have a couple of emails from people who don't really understand that rationale as it's been put out so far, such as, let's say, there's a senior who lives alone. She's in a bubble with her neighbor who also lives alone. Why can't those two receive the same consideration households are receiving? It does seem a bit strange. Will restaurants be verifying that a table of patrons live together under one roof, for example? So why can't two single people or each other's designated persons dine out together? As the senior put it, for a lift of the soul.
Yeah, that's a great question. Again, we sort of alluded to this earlier as well. We want to have that slow opening. We want to make sure that we're generating, if we are generating more cases from this opening, we want to be able to handle that and look at the next set of orders there afterwards. We can't go too fast. We know restaurants are a risky environment. If you have people from different households coming into restaurants together, it's prolonged, it's indoor, there is that risk of transmission. We have seen outbreaks, we have seen clusters related to the restaurants in Manitoba in the past. We have seen data nationally and internationally as well. From an enforcement side, we wanted to make sure that when we open something up that we're able to enforce what we desire, to limit that risk as well. So it's really impossible to enforce the bubble out in a restaurant. How is enforcement supposed to know these are your designated people? Really, we're trusting people with that. There are other ways for people to get together as well. Obviously, you don't have to go for a restaurant to a meal out. You could order in, and you can make a meal at home within that bubble as well with that designated person that you have. So we understand that this is going to be impactful for those who are single, let's say. When we had some questions on this, this is the designated, this is household only, and it is enforceable at the table level on those patrons sitting as a household and on the business side as well. So again, it's a slow opening. We get that, and we understand that there's going to be some people who are upset because they are single, but we also have to try to open things up, and we need to do that safely so that we're not generating more and more cases.
From CJOB, Will.
Yeah, good afternoon, everybody. Dr. Reimer, just going to bounce off the previous reporter's questions about congregate living facilities. I believe I heard you say you didn't know exactly what facilities in Winnipeg and Prairie Mountain you're going to be doing, but do you know roughly what order these facilities might be in? And also, when might you have more details you can provide?
So we did compile a list of all congregate living facilities in the whole province, and we broke those down by regional health authority and provided those lists to the regional health authorities. The order in the lists are based on the age of the people who live in those facilities. They're based on the health conditions and the amount of assistance people require for their activities of daily living. And they're also based on the structure of the setting as far as the ability to follow public health measures. So using those three components, we established a priority list to help inform the regional health authorities what order they should be attending different congregate living facilities. Now, certainly because there are some efficiencies that can be gained by not going to the same parts of the regions multiple times, for example, the regions are provided that flexibility to ensure that they're doing things in the most efficient way possible. So each region is taking the list and while sticking mostly to the same order that we were providing, does have that ability to make sure that they're not wasting resources in the way that they attend to different facilities. So that's why I don't have the exact list of dates and times, because we did want to ensure that the folks who were closest to the ground and knew those facilities and knew where they were located and what the logistical challenges would be, had that opportunity to inform the final order and ensure that the staffing made sense to go to each facility. But regardless of that flexibility, all of the regional health authorities are still being asked to follow the priority groupings as closely as possible.
Okay, thanks for that. Forgive me if this came up already, but can you comment on the Prime Minister's announcement from yesterday that tens of thousands of Pfizer doses will begin arriving this week? What does this mean for Manitoba?
Well, what we've heard from the federal government so far is that we can expect next week to be getting about 13,000 doses. The week after that, to expect about 15,000 doses. And then for both of the first 2 weeks in March, we're expecting 14,000 doses. That's as far as they've provided us estimates into the future. And I mean, of course, as we've seen with the previous Pfizer disruption, these are still estimates. And we know that the supply is always going to be unpredictable. But we are ready for the doses that they are telling us to expect. And we are looking forward to ramping up and increasing as soon as we have more supply. In the technical briefing today, I know that one of our human resource experts mentioned that we currently have hired 145% of the immunizers that we would require when we get to our top goal of the 20,000 doses a day. So we have folks who are waiting in the wings, who are eager to get involved, who are asking for shifts. And so we really look forward to the day when we can start to have all of those folks working shifts in our super sites, in our pop-up clinics, in our focused immunization teams. And as soon as the doses are here, we will start providing them.
Okay, great. And that kind of takes me actually into my final question. Can you just talk a little bit about your workforce recruitment targets? How many people are being trained each week, that sort of thing, please?
So I don't think I have those numbers in front of me, although let me look to see the slides from the technical briefing may have addressed it earlier today. What I can say is that we are seeking to every week be hiring and training more individuals, and that most of the numbers as far as the targets have to do with how many people we can train at a time. Because we have through Red River the micro-credentialing course that some of our individuals need to go through, as well as they need to do some training in the public health information management system. So the training does dictate a little bit how many we are able to go through each week, but hundreds of Manitobans are being trained and going through things, and we can try to get you some more specific numbers from our human resource experts after this.
Thank you.
From the Winnipeg Sun, Scott.
Hello, good afternoon to both of you. Dr. Reimer, I got to go back to this.
We'll try and come back to Scott from the Sun, CBC Radio Canada. Gavin.
Hi, doctors. First, a question for Dr. Atwal. Looking back at the summer, what would you say were the failures of the loosening of restrictions this summer, and what are you really doing differently this time around?
Well, in the summertime, I think our case numbers were fairly good. I mean, we started to see an increased number of cases as it got cooler outside. People spent more time indoors, and a lot of the business sectors are open except, maybe for events, right? So what we're seeing right now, what we're trying to do right now is try to limit those interactions. We're in the middle of winter. It's a cold snap right now. Everyone's essentially indoors. The more opportunity that we give people to interact with others in an indoor setting for a prolonged period of time does increase that risk of contracting COVID-19 if one is exposed. So we want to limit, those indoor interactions as much as possible. We want to be able to open things up, obviously, as well, because we understand closing everything has impacts on health as well. But we can't open everything up too fast, otherwise we don't know how many cases we're going to generate. If we opened right back up to where we were before, prior to our lockdowns, before they started, graduating into lockdowns, we would be generating a lot of cases right now. I think it's easy to see that. I think history's shown that. Other jurisdictions have shown that as well. So we want to be able to open up as much as we can, understand how many cases we're generating with that opening, and then look if we're able to open up some more, continue that slow, progressive opening up, and allowing those interactions to occur with people. Again, this is based on people. This is based on every single Manitoban, the behaviors of Manitobans, to limit those interactions with people as much as possible, to practice, hand hygiene, physical distancing, and most importantly, staying at home when one is sick. So we understand that there's that this is slow. But that's what we want, so we could understand the number of cases that would get generated out of this, which again, every case has an impact on the acute care system.
I understand it's based on people and they're doing what's, permitted by public health. But, do you mean to say that we opened up too fast this summer? Because that's kind of what it sounds like right now.
No, I think when we did open up, our case counts remained low. And I think what happened was as people interacted more, people probably didn't, from a behavior perspective, do as much as they could have to avoid interactions. And then as it got cooler, there was more prolonged activity indoors, which led into, an increase in cases and that exponential rise in cases that we saw. So again, we want the least amount of restrictions on Manitobans, and that's what we're trying to do, and we're going to continue to try to pursue that.
Another question about something I haven't heard about in a long time. Do you have any idea if the federal COVID-19 application is actually working? Has it, resulted in anything significant for the province?
That I would have to get back to you on. I know it's available for download. I think millions have downloaded it. I don't know the exact number. I have it on my phone. But I don't know if anything specific occurred with Manitoba. If you're asking in relation to that, we'd have to look back on that and get back to you on that. That's something we could look at.
Back to the Winnipeg Sun and Scott.
Hi, apologies for the call dropping. I have a question. So, I want to start. It's going to be a tough sell when it comes to inmates getting vaccinations before many other people. But I'll start with corrections officers because they work, closely with inmates, and nurses also do, but not to the same degree. So why does it make sense not to vaccinate corrections officers who are probably at more risk of transmitting it in the community if they are to pick up an infection inside, within a correctional facility?
Thanks for that question. I want to highlight a few different aspects that we consider when we make these very difficult decisions. The first is that we don't put any value judgment into different Manitobans. People don't need to earn the vaccine, and so we don't look at whether we're deserving, because we're all deserving, and I want to give all Manitobans the vaccine. So that didn't play into our decision making. We look at the risk. We look at what we've seen in those settings, and we've seen huge outbreaks in some correctional institutions amongst the inmates. And so it was important that we looked at the science and the epidemiology, and that's why congregate living settings broadly, but including correctional facilities, were included in that list. And we're so thankful that the correctional officers continue to work in that environment, knowing that they could be exposed at work, and we're trying to provide them the best possible protections we can. They have personal protective equipment. I know that Department of Justice has some excellent protocols that they've worked through with public health to try to protect their staff as much as possible. And by and large, those protocols are being very effective. And we are not seeing correctional officers being infected at a higher rate than other Manitobans. And most certainly, we're not seeing them experience the severe outcomes. So while I'm incredibly thankful to them for the work that they're doing, the vaccine is not a way that we can say thank you. It's a life-saving intervention. So we need to use it for the people whose lives are at risk. But that doesn't take away from the gratitude that we have for all of our frontline workers, no matter what setting they're in, and the fact that they keep going to work throughout this pandemic. So I understand that it can feel difficult how one group gets chosen over another, but we're trying very hard to stick with the science and stick with what we see about who's at highest risk. And when it comes to staff, healthcare workers specifically, there were multiple considerations that went into who got included. One of them, the most obvious, is who's the highest risk of being exposed. So we look at things like paramedics who might be intubating people in the field and are that close to an airway, and certainly exposure is something that's significant, a significant potential. We looked at who we saw were experiencing the most infections. And that's where we saw people who worked in group homes or on the acute care wards were experiencing higher rates of infection than other healthcare workers, and certainly than other essential workers. And then we also looked at which workers are most critical to maintain the healthcare system's functioning. If we had an outbreak amongst one specific group, would it cripple the system? And that's where things like lab workers or healthcare workers in corrections were flagged. There are a very small number of healthcare workers who work in our correctional institutions, and if we were to lose them, that would very quickly have a massive impact on the ability for us to provide health services in those settings. And that's also why we included the lab workers who manage COVID-19 specimens. If we were to lose that very small workforce, we don't have other people to step in and take that role. So there's a lot of different considerations that go into which groups get prioritized in what order. And so I just ask that Manitobans continue to be patient. I know that it feels frustrating and people are experiencing a lot of anxiety and wanting to know when and why they're coming up. And we're working our hardest to save as many lives as possible.
And I appreciate that, but correct me if I'm wrong then. We've had outbreaks at prisons in the province. I don't believe that severe outcomes have been very high, if any. There might have been one or two, I believe. If you look at other congregate settings, and I don't, if you maybe you can define it better for me, but you just started this off by talking about how people above 70 need it. You're not going into assisted living facilities yet. You're not going into other facilities with people in those age brackets yet, but you're going to immunize potentially 18-year-old jailed individuals. Like I'm trying to understand why that makes any sense, and I imagine a lot of Manitobans are going to wonder that as well.
So I would have two factors in response to that. The first is that the correctional institutions were not at the top of the congregate living facility lists, largely because of age. Most of the inmates are younger than we see in the other congregate living facilities. So how each RHA has decided to prioritize those facilities, I'll have to go back and talk to them individually to understand their priority list. And part of it has to do with if Brandon Correctional is high on the list, which I don't have a date for that. It may be partially just because they're in Brandon, so we're able to continue there. But otherwise, I would have to talk to the RHA specifically to understand where they may have moved that facility in the list. The second thing to consider is that First Nations people are greatly overrepresented in our correctional facilities, and we also know that they have a much higher risk of severe outcomes. So part of the reason why correctional facilities remain an important location is because we do see in our First Nations Manitobans that higher risk. And because the majority of our inmates are First Nations, we certainly worry not only about the inmates while they're in the facility, but also when they might be going back to their communities. So we'll certainly go back and we'll look at what's going on with Prairie Mountain and have some conversations with them. But the correctional facilities will remain a priority within our list of congregate living facilities, even if they're not at the top of the list.
Thanks for that. And I guess I'll follow up one more time on this. If the science or the epidemiology hasn't shown severe outcomes in jails, but has shown severe outcomes in individuals over 70. I'm asking again, why would you do that before the people? You said earlier on in your comments that are at up to 8 times more risk, up to 20% case fatality rate. So why? I don't understand how the science and the epidemiology then matches up here.
So again, part of it has to do with the fact that First Nations people are overrepresented in those facilities. We have seen large outbreaks in those facilities. In Manitoba, at the provincial correctional facilities, we didn't see a lot of severe outcomes, but we did at the federal correctional facilities. And certainly in other jurisdictions, they've seen severe outcomes in some of their correctional facilities. So we did look both at Manitoba data, but we also looked broader because we're a small province with a small population. And so sometimes we can use our data to inform decisions, but sometimes we need to make sure that we look outside of Manitoba because the variation can be substantial when you have a small population that you're dealing with. But like I said, correctional facilities were not high on the list of congregate living facilities. They were expected to be reached along with some of the other priority populations that we've already discussed. And how each RHA does their priority list is something I'll have to take away and talk with them about.
From CBC Manitoba, Bart.
Good afternoon. Dr. Reimer, this morning the vaccine team said that if Manitoba doles out all the doses it's going to get by March 8th, 40,000 people wouldn't get their second doses in a timely manner. Obviously, that's not going to happen. You folks don't do that. You hold on to you don't make first dose appointments when you don't know if there's a second dose appointment. But this implies that we're about to run out of doses for first dose appointments. That's the inference made. When will Manitoba be unable to make first dose appointments again?
So the trays that are coming in next week, we are able to book up and use up all of the vaccine that's coming in next week because we've received an estimate from the federal government that we will have enough second dose or enough doses coming in time for the second dose. So for that week, we're not limited to hold back anything for second doses because we've received that commitment to expect more doses in time for dose 2. And then after that, we'll have to make a decision week by week. I expect we will get more estimates long before we actually reach those weeks. Right now, we only have estimates up until March 8th, but as soon as we get the March 15th estimate, then we can expand the number of first dose appointments that we do the week of February 22nd. So right now, we are trying to say for the week of February 22nd, we're looking at making sure that we have enough dose available, so saving some of the March 1st and March 8th doses that could be used as a dose 2 on the week of February 22nd. And then if we get an estimate for March 15th, we'll continue to book up all of those appointments as well. So in a direct answer to the question, I would have to talk to our logistics people to get an exact number. But since we're talking about approximately half of what's being promised, I would expect that sometime in early March we would have to be focused entirely on second dose appointments, unless we get that commitment for March 15th onward, and I expect that we probably will.
Thank you very much for that, Dr. Atwal. Just following up on the variant announcement from yesterday. It's been suggested in some fairly recent reports here that this more contagious variant to be transmitted in a lot less than 15 minutes. What is Manitoba going to do to change how it quantifies a close contact as a result, given that the variant can be effectively transmitted in a lot less than 15 minutes?
Analyzing the public health measures related to that right now. In this case here, this was a traveler. Close contacts were household contacts, so there was no one else that was considered a contact, and the process worked through here. But we are looking at finalizing what that time period should be or what it should look like, and we are looking at less than 15 minutes for sure. We're looking at a couple other things as well in relation to how to manage household contacts and the expectations on those household contacts. So basically, if you're a case and you're in a household, everyone in that household, even if they were previously been able to self-isolate, we would just consider them as a contact as well. So to really encourage individuals to separate out from the household, otherwise the self-isolation period gets extended for those household contacts as well. So there's a few things that we're looking at doing there. We're just finalizing that, but public health is intimately involved with any case of COVID-19, especially there's more work done on the variant when that comes and when it did come and will continue to happen going forward.
Okay, thank you for that. Similarly, given that we are looking at a more contagious variant, a variant that can be transmitted likely in minutes than 15 minutes, what changes will you be making or resources will you be reallocating to contact tracing as a result?
So, over the past few months' time, we've done a lot from a testing standpoint to increase and look at different modalities of testing. All of the testing apparatuses that we use do detect the variant as well. From a case and contact investigation, we're looking at changing our public health measures in relation to case investigations and the messaging that's provided and the contacts as well. Our contact ability has increased as well, so we've increased the number of individuals helping us with contact tracing, and that work continues to occur as well. So there's a lot of efforts happening, a lot of different areas in public health related to case and contact management and also on the testing side as well.
From the Canadian Press, Steve.
Oh, hi there. Dr. Reimer, we had an extensive briefing this morning on the plan for vaccinations, but I'm wondering if you can give us a general comment in terms of what changes in planning, if any, might have occurred in the last couple of weeks, given the disruption in the vaccine supply, especially for the logistics involved in delivering the Pfizer vaccine, which has its own special requirements for transportation and storage?
I think that the main thing that changed was how quickly we could open up to new categories of eligible Manitobans. We had been hoping that, perhaps by the end of this month, we could be doing Manitobans who are over the age of 80, or at least starting with the highest age brackets. And that's been pushed into March, although as I mentioned, I remain optimistic that we will be able to do that in March. We also did some shifting around when it comes to the opening of the Thompson super site. The original plan had been to use Pfizer at all of our super sites, but when we experienced the Pfizer disruption, and knowing that the North needed to be prioritized along with the South, we decided to use Moderna initially at that site. So Thompson temporarily is using Moderna. And then we had the Moderna disruption. So because of the Moderna disruption, we are slowing and in some cases pausing the congregate living facilities outside of Winnipeg and Brandon to ensure that we have enough Moderna available to meet the commitments we made to First Nations communities. And I anticipate this will continue to occur. At some point, we expect that AstraZeneca will be approved, which is going to lead us to have to pivot. We'll have to look at how it's approved to be used and potentially alter our eligibility criteria based on what Health Canada decides is the eligibility for that vaccine. We know that Novavax has submitted their request for approval as well to Health Canada. And we expect that at some point there will be further disruptions in one or another of the vaccines. So this will continue to be fluid. We need to be flexible, and we need to try to respond on a day-by-day basis to the information that we have so that we can protect Manitobans and save as many lives as possible.
And on the vaccination priority list, there was talk originally about having some discussions with groups that represent frontline workers or essential workers, and perhaps developing some categories there separate from the age categories. Has there been any movement on that?
I've started to have some discussions with some stakeholders on that topic, and we plan to continue doing that. So it's still a possibility that we could expand into essential workers or to people with significant health conditions, and that work continues. In part, we're waiting to see how AstraZeneca is approved because that could change what groups are eligible. But those conversations have begun and will continue until such time as we have more concrete information.
Okay, the final question is for Dr. Atwal. Is the active case count we're now getting officially, is that more reflective of reality? Have we caught up with the backlog?
We're still off. The proxy case number is 656, and I believe the active number was 1573. So work continues to be done to clean that number up.
Our final reporter this afternoon from CTV Winnipeg, Michelle.
Hi, I wanted to ask about adding athletic therapists, chiropractors, dental hygienists, massage therapists, optometrists to the vaccination profession workforce list. Why did we add these people in if we do have 145% of staff that we need to reach 20,000 doses a day?
That's a great question. Thank you for asking that. So we have, what you're referring to is that we changed the order that would potentially allow additional groups of practitioners to be immunizers in the future. Currently, as you mentioned, we have more than enough people who have applied to be immunizers. And so I'm so thankful to Manitobans for how many have stepped up. It was really quite overwhelming to see how many people were eager to get involved and to help other Manitobans out. But that doesn't change that we want to plan for the future. We want to be ready for a variety of different circumstances. So one of the things that we wanted to have in place long before we needed it was an expanded amount of people that we could reach out to. So we're not reaching out to those groups today to join the workforce, but we wanted to have that option available because we certainly don't want to be limited in the future or scrambling in the future to find more immunizers if we find that we're having the need to hire more people. So this was really just a way that Manitoba could be as prepared as possible for a variety of different outcomes, even though right now we're not opening up the hiring to those groups.
Thank you. Just wondering also about the timelines that were in the technical briefing, the low dose and the high dose timeframes. Some of the low dose one seems to be pushed forward, like that we might be able to finish by the end of November instead, or early December instead of the end of the year? What changed there?
Sorry, I'm just trying to find the slides that are specific to that question. So we are constantly updating our estimates based on whatever information that we have available. What could have changed just has to do with what we've been told by the federal government, by the manufacturers, about what to expect. But I don't have the specifics about November in front of me, so I'll have to look into that and get back to you.
Okay. And then with the vials being 6 doses per vial, do we still have the adequate syringe tips or that we need to do that for the foreseeable future?
So we're using 1 milliliter syringes for Pfizer, and that has been an essential component of ensuring that we get those 6 doses. And there is a global shortage of the 1 milliliter or 1 cc syringes. Right now, we have enough, but we also know that we will run out. And the federal government has told us that we can expect additional shipments of that syringe. So right now we are planning with the assumption that we'll be getting the syringes as indicated by the federal government. If we do, then we'll be able to continue getting those 6 doses from each Pfizer vial. If at some point we don't have those syringes, we can expect what has been seen in other jurisdictions where 5 doses is what's gotten if you're using a 3 milliliter syringe, for example. So for today, we're doing okay. We have enough syringes, but unless we get that shipment from the federal government, we will run out.
Thanks, everyone. This concludes our media briefing.